So what I'm going to do is take this to another level and to talk about the patient. A lot of the patients that I might see in referral are having more severe symptoms referred from out of state. And I want to give you a next layer of moving more from gut to brain, actually, with chronic and severe pain. This, by the way, is a patient who I saw with Crohn's disease, and the tattoo says, "Feel my pain." I'm going to start with the case history, and the reason for that is I want to get you in the right mood for what we're talking about. This was a patient who was referred with chronic and severe abdominal pain that was refractory to all prior treatments coming from out of state. She had a history of recurrent abdominal pain at age 6 and had school absences. This increased after menarche. At age 19, she was traveling through Mexico and got an acute gastroenteritis, what sounds like post-infectious IBS, and in fact was diagnosed with IBS at that time. Over the last 10 years, the pain became more frequent, and over the last 5 years, the pain was constant and associated with bloating and constipation. She also reports fibromyalgia and occasional migraines. She was on a variety of medications, including antispasmodics, proton pump inhibitors, gabapentin, lubiprostone, none of which helped the pain. She had several procedures, 2 colonoscopies, EGD, CT scan, capsule endoscopy. You can read what was done. 5 years ago, she had an exploratory laparotomy, was diagnosed with possible endometriosis, and had no response to leuprolide, which is sometimes used as a GnH agonist to affect motility in the gut. She had a cholecystectomy 3 years ago due to low ejection fraction, what we call gallbladder dysfunction. And again, nothing was resolved. What about her health behaviors? She had over 30 emergency room visits, receives morphine and phenergan. She's usually discharged with a weak supply of narcotics, hydrocodone or oxycodone. Family physician refills the narcotics to prevent repeated emergency room visits. She's had 5 hospitalizations for pain when the emergency room treatment is unsuccessful. And a month ago, she came in the hospital. She actually had a second exploratory laparotomy, which was negative. Postoperatively, because of the pain, she got increasing morphine. And then they were unable to discharge her because of continued pain. What do you do in that situation? Here we are, can't get her out. What do most docs in the hospital do? They got a psychiatry consult. Psychiatry consult said she had major depression with post-traumatic stress from early childhood deprivation and sexual and physical abuse. Her parents were divorced when she was 12. She left home at age 16, became pregnant at age 17. Left her spouse after 4 years because he was doing physical abuse, currently living with her mother. The last 2 years, unable to work as a fast food clerk on disability. What did the psychiatrists do? They recommended paroxetine and follow-up at a local mental health center. Obviously, she did not go to the local mental health center. She was discharged on this medication, and now she shows up in your office, curled up on her side with her hips flexed, complaining of severe cramping pain in the mid and lower abdomen and with nausea, and she requests hospitalization to find the cause of the pain and to get IV pain medication. You ever seen anything like this? Okay. Well, that's what we're going to talk about. Any initial observations of where you think we are or what you might want to do? Aaron?
She has narcotic bowel syndrome.
Ah, okay. So let's think about that as an option. Okay, so the general observations are, well, how do you feel about this patient being in your office? Let's start with that. What are your thoughts? your options for success.
I mean, part of this is a reflection of the healthcare system, where patients will go to an emergency room. They're usually not going to be admitted. Sometimes they are, and they're given IV narcotics. Even being hospitalized, they're given, I mean, morphine is, to me, on order forms like Tylenol and milk of magnesia. You know, it's like very standard to be on the order form nowadays. And then because they're not quite sure what to do with the patient, then they get discharged, and then they sometimes even give them a oral opioid, and then you're kind of stuck again. And then the follow-up is difficult because then you're stuck now. What are you going to do about the patient's pain and the fact that they're on opioids?
So being stuck is a common experience.
Yeah, at our place, it's typically they get seen in the ER, and they get put on narcotic, and then it's emergency GI consult. And then they get put in some of our clinics to sort it out. So this is not an uncommon scenario at all for us.
You're also getting a sense that she was sent to the psychiatry, but it comes back to the medical doctor because her schema is that this is a medical problem that requires.
In our community, too, I try to get people with substance abuse involved. As a secondary, she's dependent on opiates now. And, it becomes a vicious cycle to break. So this way you try to get multiple modalities involved.
Okay. Well, she has several diagnoses. Actually, if you follow her history, it started with recurrent abdominal pain, functional abdominal pain in childhood, because she had those episodes when she was a schoolgirl. Then she got her post-infectious IBS. So we're seeing this kind of accelerating course. And her diarrheal condition went to IBS-C. Then she got functional abdominal pain because we're using the Rome rubric here that it became constant and not necessarily related to bowel habit, whereas earlier it was. And then she got narcotic bowel on top of that. So we're seeing that there's an overlapping of conditions and a transformation. The question is, how could that be occurring? And I do want to make some observations about at least the frequency. This is skewed a little bit, but the functional abdominal pain is relatively uncommon. But when we get to severe IBS, we're kind of approaching functional abdominal pain. The main difference is the bowel dysfunction. With functional abdominal pain, you're characterizing it by not having the bowel dysfunction. And generally, the psychosocial distress gets, as the IBS gets more severe, the distress and the findings get more severe, very similar to functional abdominal pain. The rest is pretty similar, but the treatment methods, is to point out, is with the mild or moderate IBS, the kind that Bill was talking about, you're talking about a lot of bowel treatments, but as you move up to the more severe and constant pain, you're going with more centrally targeted treatments. This is just the criteria for functional abdominal pain. You notice that it's continuous or nearly continuous, no relationship or only occasional relationship with pain or pain with physiologic events, because IBS usually often worse with eating, relieved by defecation, and so on. Some loss of daily functioning, and this is not malingering. So this kind of graphically describes what may be happening from an epidemiologic standpoint. Someone who comes in with a bowel obstruction or an acute cholecystitis is being drawn from a general population. The prior probability of psychopathology is probably no different from the general population. And their health behaviors is moving toward getting better. Their expectation is that they'll get better. And as a result of that, you treat the peripheral problem and they get better. Once you get a chronic condition, whatever it is, it starts to impact on the individual, where you're starting to get interactions with the family, chronic disorder, IBD, issues around disability. Once you get to a functional GI disorder, there might be more central representation. And then when you get to functional abdominal pain, you're in a situation that we call an abnormal perception, where there's normal gut function. Everything is upregulated from here, and the brain is responding to regulatory activities. Right now, your gut, if you don't have pain or any discomfort, you feel nothing, but there are signals from the gut going to the brain. It's just that it's subliminal. People with functional abdominal pain, it's upregulated. Here's an example to show that with visceral hypersensitivity. Looking at perception threshold testing, IBS is shown at the bottom, the yellow line, but functional abdominal pain and controls have a higher perception threshold. And this suggests that you don't have visceral hypersensitivity in the patient with chronic abdominal pain. And Bill and Spencer Dorn in our group was able to show that the pain is often a central phenomenon anyway in terms of sensory decision theory. This is just showing that the more severe the pain, the more you start to look at psychosocial variables. We mentioned narcotic bowel. I'm going to go quickly through this because I want to get to the treatment. We know that this is a CNS phenomenon, primarily due to activation of dorsal horn glial cells. There are other mechanisms, but these are inflammatory cells that can lead to neuronal excitability and enhanced pain. We actually have a paper currently in press, we just finished the galleys, showing that detoxification, taking them off the narcotics, leads to improvement in pain. What are the psychologic diagnoses? No time for this. Key points about major depressive episode for a medical clinician is that you don't have to have depressed mood. You can have anhedonia, that is number 2, markedly diminished interest or pleasure. It's common for medical patients when depressed to say, I'm not depressed, or you'd be depressed too, but if you ask them, how about your interest in doing things? I don't have that interest anymore. That's a sufficient criterion for major depression, along with the other factors here. She also had post-traumatic stress disorder as a result of her abuse. Again, I'll refer you to, we could talk about this later because of time. I want to just say something about the brain-gut axis. Lynn has already talked about this. There is evidence for, this is a study we did of women with abuse history and IBS with rectal distension, and you're seeing activation of this mid-cingulate and posterior cingulate in red, and that, if you look below it, it correlates with their pain, and you can see on the right side that their pain reporting on a scale of 0 to 5 was significantly higher than those without the abuse. So what we're talking about probably is that the pain modulatory center is activated or upregulated by the presence of psychosocial distress. This is a case of a patient who was treated, and you can see in the second brain, vertical brain, how the cingulate area, the activation got less, as did in the third area, the somatosensory cortex. So there's some evidence that this might be working. This slide is showing you kind of an epidemiologic picture of what we see, and if you're in practice, you're probably seeing moderate, mild to moderate, and as you move on to the referral centers, you're getting to the more severe, and this is what leads to this kind of an upregulation of treatment from what Bill was talking about through the gut medications to what I'd be talking about, the behavioral and antidepressants. The hottest thing now in terms of this area, again, borrowed from psychiatry, being seen in other medical conditions, is what we call neuroplasticity, neurogenesis, and treatment with augmentation. These chronic pain conditions are associated with reduced neuronal density. We knew about this with Alzheimer's and Parkinson's disease, but certain areas like the cingulate, the cingulate and areas that are associated with pain regulation are associated with reduced neuronal density. And now it's coming out in chronic pain. Chronic pain is a neurodegenerative disorder. The good news is that antidepressants and psychological treatments may reverse this process and regrow neurons, and this is what we deal with many of our patients. And the way we do this is by using low-dose combinations of medications and psychologic treatments. This is the theory by Tariq Pereira, who spoke at the Rome AGA conference last year. And it's really saying that there can be vulnerabilities on the left side that under the persistent stress, whether it's drug abuse, social stress, or chronic illness, they get an increase in vulnerability, and this can lead to clinical issues of depression, and also it can lead to suppressed neurogenesis. The nerves start to become lower in density, and with treatment, there's some evidence for increased neurogenesis. Here's an example of Gulf War veterans showing that with post-traumatic stress disorder, they have decreased hippocampus head volume. and that's associated with delayed verbal memory. Here's evidence that came out with somatic pain, showing reduced density in the anterior cingulate and the ventromedial prefrontal as well as the postcingulate. Those are areas we've been talking about. And here's evidence from IBS showing decreased thinning of the anterior mid-cingulate. And here's a paper that just came out showing that with chronic painful pancreatitis, at many, many areas, there's reduction in cortical thickness. So the message seems to be that there's some kind of neurolytic process going on. Perhaps one theory is it's the stress, it's the certain peptides or excitatory amino acids that get released that may lead to this degeneration. And here's evidence that with treatment, you can increase BDNF with improvement in depression, and the longer you use it, the higher the BDNF. BDNF is brain-derived neurotrophic factor, which is a trophic precursor of brain growth, brain cell growth. And this is just to say that this occurs in the periphery as well. Mike Gershin has done a series of studies now showing that if you add tegaseride, a 5-HT4 agonist, to a cell bath of neuronal myenteric neuron cells, you'll get increased neurite outgrowth and decreased apoptosis, and this does not occur in 5-HT4 deficient knockout mice. Management approach, doctor-patient relationship. Bill talked about this, and so I want to add a caveat. In the mild to moderate, the type of symptom is the preeminent thing. In the very severe, the severity of the pain is the preeminent thing. That's why they're coming to you, but you have to do both. And that's where we deal with narcotic withdrawal and do this multidisciplinary approach. Do we have a narcotic bowel? You said we had a narcotic bowel paper there. This is showing, I'll talk about this in the next talk, the augmentation, and that's it. Quickly.